Hello. Today I will presenting patient JS, a 73-year-old male admitted to the General Hospital ER on March 4th, 2024 for a lab report follow-up. His chief complaint is that he's been feeling sick and his physician called him this morning and told him to come in due to abnormal lab results. The history of present illness is that he was recently hospitalized for a UTI and received IV meropenem outpatient through a PICC line for 2 weeks. It is of note that he just completed meropenem 3 days ago. Since then, after stopping meropenem, he had chills and fevers shortly after and saw an ID physician 2 days ago to get some follow-up blood work. This morning, his ID doctor told him to go to the nearest ER due to the abnormal lab results. His past medical history is rheumatoid arthritis, diagnosed 15 years ago, hypertension, and bipolar disorder. Surgical history, social history, and family history are non-contributory. His allergies are levofloxacin, which causes a dizziness, and then he's allergic to peanuts, which causes shortness of breath and swelling of the lips. For his home medication, the patient is taking Enbrel 50 milligrams subcutaneously every week, with the last dose taken 5 days ago. Naproxen 1,000 milligrams by mouth every 12 hours. Lisinopril with hydrochlorothiazide of 12.5 milligrams by mouth every day. Aspirin 81 milligrams by mouth every day. Lurasidone 40 milligrams by mouth every day, and mirtazapine 30 milligrams by mouth daily. With a review of symptoms, constitutionally, the patient generally feels ill, otherwise negative. For vital signs, there was an elevated temperature of 39.3 Celsius that predicts a fever. Other vital signs are within normal limits. The patient is 69 kilograms and 74 inches. With the serum creatinine of 1.0, the creatinine clearance is 64 milliliters per minute using actual body weight of 69 kilograms. The physical exam showed the abdomen was positive for bowel sounds. Other exams were within normal limits. Labs were done, and TB skin tests and hepatitis B tests were negative from 1 year ago. And from March 2nd, the lab showed elevated white blood cells count at 12,400. Segmented neutrophils were elevated at 68. The BUN was high at 28. There was a low calcium at 8.5, and the total protein was low at 4.0. The labs were done at the Central Clinic back in March 2nd via the PICC line, and there was a gram-stan positive for yeast in their aerobic, and the final culture actually showed Candida parapsilosis, which is susceptible to micafungin, fluconazole, and voriconazole. On March 4th, at the General Hospital, they did get 2 blood cultures via gram stains, one from the peripheral left arm and one from the PICC line. Both aerobic bottles showed yeast, and the anaerobic for both bottles showed no growth. They did start an ECG for 12 lead on March 4th, but showed a normal sinus rhythm with a normal sinus rhythm. Therefore, at day 1 plan was to repeat blood cultures and to start micafungin 100 milligrams IV every 24 hours, resume Enbrel, hold the naproxen, resume lisinopril hydrochlorothiazide, and resume bipolar medications. 24 hours since admissions, there was a progress report that showed that the patient feels the same, still having fevers and chills, and no significant events overnight. With the vital signs, the blood pressure shows elevated at 134/92. Heart rate and respiratory rate remain stable, and the temperature is still getting better, however, still showing a fever at 38.5 Celsius. the serum creatinine of 1.1 with a creatinine clearance of 58 milliliters per minute using actual body weight of 69 kilograms. The physical exam showed non-remarkable of the 24-hour progress. The lab showed white blood cells are downtrending at 11,100. Neutrophils are also downtrending at 64. The BUN remains high at 29, and the calcium has normalized to 8.9. The key problem today is uncontrolled invasive candidiasis of systemic candidiasis due to Candida parapsilosis. The patient key evidence were persistent fever for more than 2 days, and her PICC catheter line shows a growth of yeast, specifically Candida parapsilosis. The patient was also on a broad spectrum antibiotic of meropenem as well recently. And for some host-related factors, patient has rheumatoid arthritis, can be an immunosuppressants, patient's older age as well. And yeah. So for therapeutic goals, our goals is to eradicate the infection, decrease morbidity and mortality, and prevent recurrence and relapse of the fungal infection. For stop and modifying, we want to stop micafungin 100 milligrams IV daily. We are actually going to modify and decrease the strength of lurasidone from 40 to 20 milligrams by mouth daily due to the CYP3A4 interaction. We're going to start fluconazole 800 milligrams IV once, followed by 400 milligrams IV once daily for 2 weeks. Day 1 of therapy would be starting after the Candida is cleared from the bloodstream. For non-pharmacologic, we want to remove the PICC line as early as possible. We want to have good hygiene and protected environment and repeat our blood cultures every day. For efficacy monitoring, we want to see signs and symptoms of resolution such as fever and chills. We want to see status of source control after removal of the PICC line to make sure after remove the PICC line, there is no further Candida. We want to see normalization of the white blood cells and follow up with the blood cultures every day or every other day to establish a time point of when the Candida would be resolved. Safety monitor parameters would be liver functions to watch for hepatotoxicity. We want to look for hypersensitivity such as rash, and then QTc prolongation. Thank you.